All right, for those of you that are on WebEx, we just finished the Ways and Means meeting, and we're probably going to take about a 12-minute break, and then we'll get started. So just want to let you know about the delay. Thank you. All right, we're going to call the meeting to order. This is the Subcommittee on Ways and Means informational hearing on the T1000 specialized medical care as related to the TA waivers. And we will begin with Matthew Moore from the Legislative Research Department. Matthew, are you on? Matthew's not on.
Oh, I am here.
We can hear you.
Wait. Just provide a brief overview of the T1000 code for the TA waiver. Just a little bit of background. The TA waiver is aimed at individuals under 21 who are dependent upon a medical device for a vital bodily function, such as a ventilator for breathing.
Matthew,
these services are general.
Matthew, do you have a handout?
Yes.
You do?
I don't.
No. Oh, okay.
I,
all right. We just didn't know if we were following. All right. Go ahead. Continue.
Yep. So these services are generally comparable to maybe nursing services that they might provide in a hospital setting. The idea being, rather than have hospitalized care, they would be receiving these services within the community. Just a little bit of history in terms of the increases. In 2017, the legislature added a 3% increase for all waivers. This accounted for about $1 increase for the TA waiver, particularly this code, but it was for a broader increase. That took effect in FY18. It also included a 4% increase, which was about another $1 increase that took it into account in FY19. There was another increase by the 2019 legislature for a 1.5% increase effective 2020. That accounted for about a 50-cent increase to this particular code. The first real instance that I found of a dramatic increase in the waiver was last year. The legislature did pass an increase for this specific code. That was in the House. They originally proposed a $47 increase. The Senate went with a 39% increase, but it was settled on a $37 total for the code, which went through, made it into Senate Bill 66, but then was subsequently allotted by the governor. And then currently right now, I believe the Senate position was a $37 rate. And I know that the House is currently, the recommendation was for the $47 increase. And with that, I would defer to the agencies to kind of describe a little bit more of what their stances are in terms of the savings or any particular thing about this particular code.
Any questions for Matthew? All right, Matthew, thank you. We'll move on to Amy Penrod, Commissioner of KDADS.
Good afternoon, Madam Chair and members of the committee. My name is Amy Penrod. I am the Commissioner of the Aging and Disability Community Services and Programs group at KDADS. Matthew covered most of what I would have updated, kind of giving that overview of the waiver and who it serves. Specialized medical care, which is the T1000 service, is a key TA waiver service. It does provide the long-term registered nurse or licensed practical nurse support to our waiver participants. I would say that, competition for qualified and licensed nurses is at an all-time high, and these are challenging to provide hourly rates that are adequate to recruit and retain the nursing staff needed to provide adequate services to our waiver participants. In my testimony, I provided that basic overview and then also some information about our current hourly rate. The current hourly rate for specialized medical care is $31.56. That is actually a $7.89 per 15-minute unit rate. We have also provided for you an estimate of the state general fund and all funds increases needed to support a $37 per hour rate, and then also a $47 per hour rate.
Amy, did you say you had some testimony?
Yes, it is in a memo form. It is on KDAD's letterhead.
Is it which one? I got two of these. You guys have something different? I don't have that other one. You guys have this one?
I believe it's in your left hand, or it was in your left hand. Looks like that was mine. It's a single page.
Okay, I see. I get it. You have a one page. We got it. Thank
Okay,
you.
great. Absolutely. I would note that the costs associated with increasing the specialized medical care rate would need to be addressed in the KDAD's budget. And then I believe you have KDHE on deck to discuss the information pertaining to hospital utilization and what that might look like on the flip side, as far as any savings or the position of the agencies on any savings that may occur from this rate increase. So with that, I know you have some other folks you want to hear from, so I will stand for questions at the appropriate time.
You'll be able to stay on the line. All right.
Yes.
Thank you.
Mhm.
Next, we have Sarah Fertig, the State Medicaid Director of KDHE.
Thank you, Madam Chair. My name is Sarah Fertig. I'm the State Medicaid Director with KDHE, and we also submitted some written testimony, Madam Chair. Okay, you've got it, great. We would agree with everything that Amy Penrod just said. She gave some good information on the purpose of the T1000 code and rates. In the past, KDHE has been, we've been asked more than once to try to calculate how much savings could result in unnecessary hospital stays if we were to increase the T1000 rate. And we have tried more than once to try and calculate that number, and we're not really able to do that because the effect of that rate increase is maybe too remote to specifically identify any savings that could result. As we lay out in our testimony, there are a number of reasons why a particular TA waiver case could be difficult to staff. The rate could be one of those reasons. But trying to draw a direct line between a rate increase and an avoided hospital day is something that we don't think we could do with any certainty. That said, we would support a rate increase for T1000. We do think that $31.55 an hour is probably very much below market rate, especially considering the types of services that these beneficiaries require and the type of hands-on, very detailed work that's necessary to keep them healthy and safe. We would just ask that if that rate is increased, that the rate increase not be based on an assumption that we would generate a dollar-to-dollar savings on the hospital side of CanCare expenses, because if there are savings to be gleaned from increasing this rate, we think that would happen a couple years down the road and definitely not overnight. We can't increase a provider rate and have the provider network expand overnight. It takes some time. So we would just ask that if the committee sees fit to increase the rate, that it be done with new SGF rather than under an assumption that we can just switch dollars from perhaps the KDHE side of the CanCare ledger to the KDAD side. And Madam Chair, I'd be happy to answer any questions the committee might have.
We did increase the rate, but you could track it, I think, couldn't you, going forward if we had fixed numbers? So you have 2,000 people served, whatever it is, and this is what your costs are through the MCO, and then in 2 years or whatever that we see, we could determine that there's a change. of that same population served, or that same amount of the number served.
Yeah, in the aggregate, we certainly could. I mean, we're able to identify inpatient days for any of our CanCare beneficiaries if we needed to. So we could isolate the TA waiver population and look at the number of hospital days that we've seen over the years. So we certainly could do that, Madam Chair.
Any questions for Sarah? Senator Petty?
Thank you, Madam Chair. That 605 that are served with the TA waiver, is there a, I'm sorry, I have food in my mouth, I'm trying to, is that a pretty static group? Or since it has it only serves up to 21, is that, or age 21, is that correct? Is that what
That's right.
So I would assume there are high needs children that stay on for a very long time, but then at the same time, there's probably a group, I mean, there's a portion that would go off for a variety of reasons. So how is it measurable? Can you use those parameters to measure it, the need of hospital care, as opposed to being, if there is an increase, how that would measure up? I don't know if I said that.
Well, Senator Penny, to answer your first question, that number does stay pretty stagnant. You'll see in our written testimony, as of December, there were 590 TA waiver members, but it tends to fluctuate somewhere around 550 to maybe 625. So those numbers do stay pretty steady over the years. And you're absolutely right. There are some kiddos on a TA waiver who, when they're born and released from the hospital, they are requiring technology, and they continue to require technology throughout their youth. So there are some kiddos like that. There are other kiddos who might not need waiver services for quite as long. Amy Penrod would probably have more information about how that distinction tends to go, but there are definitely kiddos on a TA waiver who experience much higher levels of hospitalization than others. And we would have that information, Senator Petty, if that was information the committee needed.
So just to follow up, so as you're saying, I understand what you're saying about that there shouldn't be an assumption made if there's an increase in this T1000 rate, that doesn't necessarily, that should not be matched up to, hey, increase here would be reduction in hospital days here. But as the chair had asked, you could measure over time whether it has become a factor.
I think we could in the aggregate. One of our challenges is that CanCare does not maintain medical records. And truly, the determination of whether or not a particular day spent in a hospital in an inpatient setting is avoidable, that's really a conclusion that has to be drawn by a medical professional after reviewing the patient's records. And we don't have those records. So the state wouldn't be able to get into that degree of detail, but we certainly could track over the years if we saw a decrease in the number of hospitalizations per TA waiver beneficiary, one-on-one or in the aggregate. And there may be some kiddos who just the nature of their conditions and their medical needs, they're going to end up in the hospital more frequently than others. And that could simply be, but we absolutely do have the ability to track and report back, what we're seeing in terms of trends and hospitalizations.
Thank you.
Sarah, we may have received this when we had our regular subcommittee hearing, but do we have numbers about that some of these TA folks in need, it's at birth, and then also whatever, whether car wrecks or different ways that people end up getting brain injuries? Do we keep any of those statistics on these folks that are in there?
Amy Penrod might have a little bit more information on that. The information that we would have on the KDHE side we would be able to identify the age of the kiddo when they went on the TA waiver. And sometimes you can discern that, yes, this was pretty much right after birth when they were released home. So we can identify the age at which they entered the waiver, and that could give us some information. Possibly in some of our data, we might be able to suss out a diagnostic code to see if there's something that could indicate that the need for the TA services came on later in childhood. But I might defer to Amy. I'm not sure what all information that they maintain on the KDAD side with regard to that population.
And Amy, what I'm trying to get at is, I can't remember what it was, but there was another entity that it's in KDHE actually, and I can't think of the program now, but where they look at accidents and so that they can do prevention. And so that's what I was looking at, Amy, is if, say, 20% are at birth and then the rest are because of some kind of accident, do we track any of that for prevention purposes?
As far as the waiver goes, I don't believe that I do currently have that type of distinction. Like Sarah said, we could determine when an individual comes onto the waiver. Otherwise, I think the information would be very individualized from one child to the next, and would require some case review in order to pull out kind of that categorical type of data.
Well, and what I'm thinking of, and I'll go back to Sarah, and I have to go look at my notes because I just can't pull out the files in my head all the time. But because I remember having this conversation with Ashley Goss as to whether or not you needed that program. Do you remember now what I'm thinking of, Sarah, where they do statistics?
I think you were referring to the trauma program. Is that it?
That's probably it.
I'm not tremendously familiar with the suite of programs they offer on the public health side, but I could certainly circle back with Ashley Goss and see if that's something that they track.
I can pull it up, but you're right. That's what it's called, the trauma program. And Liz Dunn sent me a PowerPoint that was really helped, and I'll make sure these two have that as well. All right, well, we'll move on back to the T1000 services. And were you finished, Sarah, or are you just waiting for questions? You're down there.
I was waiting for questions, Madam Chair.
Any other questions for Sarah? Okay, I don't see any right now. Thank you.
Thank you.
Next, we have Amy Campbell, Association and Governmental Relations Services. Welcome.
My name is Amy Campbell. I'm here on behalf of the providers for the specialized medical care services. Today, I have with me in the room Matt Johnston from Maxim Healthcare. On WebEx, I believe we have Sean Balke from Craig Home Care and Ann Martin from Thrive SPC. This is my overview. I did attach onto the back the testimony provided to the subcommittee on this issue, so in case you wanted to refer back to that. But I've tried to condense our primary points just on this cover sheet. This issue has gone through your budget committee, House Social Services Budget Committee, and the Robert G. Bethel Joint Committee on Home and Community-Based Services and Can Care Oversight for the last couple of years. And we really appreciate your work to include a line item in the Senate mega budget bill this session. The providers are requesting that the rate be increased to $47 per hour, and I have bulleted here the list of reasons that come from the testimony that's been provided to you. The current rate of $31.56 per hour is one of the lowest in the country. The current rate only provides approximately 65% of the authorized services in the community and significantly less in the rural areas. That means that there are patients who are authorized to receive these services, but there is no one to provide the service for them when they are discharged. I would just point out that that is the area of avoidable cost that these folks have targeted, in the sense that folks are ready to go home from the hospital but they cannot be released until the services are going to be available in the home because of the medically fragile nature of those patients. I'm going to skip ahead a little bit. $47 is not a high rate. It would be a midpoint for this rate as to what's offered by other states. Reducing hospital days obviously reduces costs to the program. As a result, now there's kind of an analysis attached to the KDHE testimony that had come out a year ago. As a result, the Bethel Committee asked for a more targeted analysis of actual costs related to actual patients in this waiver program. Matt, who's in the room today, worked with representatives of the agencies to get that data, and that's the analysis that we have before you here in my overview. So in 2019, the number of Medicaid recipients was 528. They received an average of 52.5 hours of service a week. So that is different than the analysis that you see attached to the KDHE testimony, which used an assumption of the maximum number of hours that a patient could receive in a week. This population used 95,018 inpatient hospital days, and the cost was $1.5 billion. After reducing the number by the percentage who already have a primary insurance, that leaves $880 million in Medicaid hospital cost, 55,291 hospital days. So,
I'm sorry to interrupt you. I just want to understand on the folks that you serve, are these generally 8-hour or how? What are most of them? Are they there all day?
that is an excellent question, and I would, Matt, do you want to answer that question?
You can. I mean, if I'm jumping ahead, if you can address that next, because you're going to speak to, aren't you?
No, I'm just going to do the overview, and then we have all of these folks here for you to ask questions, because I didn't think you wanted us to repeat the testimony that you've already received. So, and Ann Martin, who is online, did not provide testimony initially, but she is a registered nurse who works for Thrive, and so she can also answer specific nursing questions if you have those as well.
I'll let you go ahead and continue, and then Matt, you can follow up. Thank you.
That sounds great. So that is where this analysis came, saying that reducing hospitalizations by 1.02% could cover the SGF cost of the increase. And so the point is not that these providers believe that you should use cost savings to fund the increase. The point is to say that putting the SGF in to make this increase is going to result in cost savings. However, the legislature would choose to fund that, obviously, we would support. And we absolutely do understand the agency's hesitance in transferring funds from one agency to another and the jeopardy that they see in that technique. Our point is that these providers would only need to cut back 1.02% of the hospital days that people are waiting for services in order to cover the cost of the increase. So with that, that's our data. Sarah Fertig has already explained to you how that data can be tracked and reported annually through their aggregate data. We agree with that. We would certainly stand ready to support them in any way possible to get that done. And then with that, I would just stand for questions, Madam Chair.
Questions for Amy right now. Senator Petty.
Thank you, Madam Chair. Amy, on your bullets there, you made reference to that the recipients received an average of 52.5 hours of service a week. And then you said that, but yet the service was figured at a different rate.
So the reason that the Bethel Committee asked these folks to meet with the agencies and sit down and get actual numbers related to actual services that are being provided under this waiver is because the analysis that had been provided before that was based on some assumptions. And I'm not going to fault those assumptions. If I'm the budget person for that agency and I'm looking at future costs, sure, I'm going to base my calculations on the absolute most that it could possibly cost. But we believe that this analysis is more accurate because it's based on what are these patients actually receiving. So what can we expect that those costs would be? Does that make sense? It is literally it's just a different methodology based on actual experience instead of looking into the future on what is remotely possible.
You're saying this number is based on actual experience.
That is correct. And it is also was put together with the participation of representatives of the agency to get that data.
Okay, thanks.
Matthew, you want to come up and please identify yourself?
My name is Matt Johnston. I'm the Director of Business Operations for Maxim Healthcare.
All right. So my question had to do with, are these folks cared for a few hours a day, around the clock? How does that work generally?
The way it usually works is a significant portion of the population does have ailments from birth. So normally they'll come out of the hospital and for about 2 weeks they receive 24 hours a day care. That's 168 hours a week for 2 weeks. They usually then transition down to about 16 hours a day and step down as the disease process either progresses where they need more care or less. So the average of 52.5, it's coming out about 8 hours a day is the average on the 528 participants we did an analysis on.
So if you had a choice for this kind of care or no care, would they otherwise stay in the hospital? Would they generally stay in the hospital that whole period of time? Or would people maybe just go home and not receive care?
Traditionally, especially in the neonatal, the very small, they will be held in the hospital as the care is continuous and it would not be able to be provided without the services in the home. So that is where a significant amount of delayed discharges come from, is as you're setting up the home care services, there's not a provider in the network that would be able to provide those. So they have to wait in the hospital until a team of nurses is built to be able to provide it.
And they usually stay consistent, so I assume you have, what, 3 or 4 nurses, and they're probably 12-hour shifts.
Yeah, 8 to 12-hour shifts would be the most common, especially from a 24/7 when they first come home. You want the most amount of continuity of care possible. Our approach is usually 12-hour shifts to have as few nurses in the home as possible to have that continuity to see if there's any decline in the patient.
Do you stay consistent with the same nurses?
We try our best, but there is significant amount of turnover due to the amount we can compensate.
So just along those same lines, is the issue with having a quality nurse to provide service, is it only tied to pay, or is it also tied to the workforce capacity?
There's a certain population of nurses that are not going to desire this setting. An acute care specialty nurse traditionally doesn't transition into home care. The rate is what is prohibitive for us to, analyze of the entire nursing population who would actually want to provide this level of service. So it's really more driven by the rate, because at 60 to 70% of what a nurse can make in almost any other facility, it's hard for them to even make that decision from a financial standpoint. There are a significant amount of nurses who desire to work in this field, but simply cannot due to the financial hit they would have to take.
What is and it may be in here, but the level of training for all of these nurses? Do have to have a background in brain care specialty or?
There is not a regulation that mandates any specific training outside of a nurse having a license. A nursing license. Either one, LPN or RN. It's a merged rate, so either nurse could provide those services, with the exception of a small population of patients that require an RN. That would have to do with if there was, it's called TPN, feeding through the heart, very specific things, but that's a small population that would receive that level of care.
Is there a rate adjust? Is it going to be everybody gets the same rate? Based on, so if you're
The reimbursement is consistent. Obviously, as a provider, there would. I can't speak.
And then you decide what they get.
Correct.
Other questions for Matt? I don't see any right now.
Thank you.
Amy, my pencil lead wasn't working. You said you have Sean and someone else online.
Sean Balke from Craig Home Care and Ann Martin from Thrive SPC should both be available on WebEx.
Sean, would you like to make a few comments? You're muted.
I'm sorry, Chairman, again, was that directed to me? I couldn't hear you.
There you are. Sean, I just wanted to know if you wanted to make any other comments.
Thank you, Chair. Yeah, I really appreciate the opportunity. I want to thank also our partners, Amy Penrod, Sarah Fertig with the agencies. It's been a really very good process to work through this issue, and certainly very helpful that they've participated in providing some of the resources to help identify some of the data and understanding the issue thoroughly. So I want to thank really everybody, and then certainly thank this committee as well as the others that we've had the chance to work with. I will echo a lot of what Matt has already said. Certainly his responses about the nursing population and the reasons why this rate is so important. Really, if you look at the labor population for nurses, and every market's different, and I know Maxim provides services in other markets, and so does my agency. The supply and demand ratios are a little bit different. Certainly in Kansas, there's a tremendous amount of competition for nurses in acute care clinics, other long-term care settings that can provide a higher rate of reimbursement. And so really the rate that's there now, to get kind of into a detailed point, only allows us to compete for less than 50%, by far less than 50% of the nursing population that's out there. And so what we're trying to do by even getting to this midpoint number is allow us to get up to a competition level that approaches that 50% of nurses, so that we can try to capture more of those available that would be able to provide these services. So just wanted to make that point. It's so non-competitive now that there simply is no way, regardless of the interest in a lot of cases of the nurses that are potentially interested, they just can't make that financial decision to take a rate that's so substandard as it relates to what they can make in the market. And then the other point that I'll reinforce, I am currently the only agency that provides services in rural areas of Kansas. And that is a profoundly impacted part of the population by this issue. Those numbers that were reported of the authorized hours and what's covered, those numbers go down dramatically in the rural areas. And it's pretty interesting if you look at some of our data. The rural areas, you would think that certainly the labor supply is going to be a little bit thinner in a lot of areas, but nurses can actually make a higher rate of pay in a lot of the rural areas because there are so few of them and the need in those areas is significant. So getting to a rate that is allowing us to be competitive is certainly important in the urban areas, but it's critically important in the rural areas. Those rural families that are making sacrifices and trying to bring home children from a hospital, acute care hospital like Children's Mercy in Kansas City or Children's Mercy in Denver. It's unbelievable the amount of challenge and difficulty it takes to provide a transitional process and then sustained care for a child with those type of needs when you're traveling several hundreds of miles, across areas where there's not good, medical care and support if there's a challenge. And our nurses are on, they're on an island when they're out there. If they're providing service for a patient that's 200 miles away from the closest hospital, there's no backup, there's no support, and to that issue of training, we're trying to make sure that whether it's a seasoned nurse who has done this kind of care for a while, or it's a new nurse who just graduated and is looking to, be able to provide care in their home community rather than go move and work in a different, community somewhere for a facility, we have to be able to provide that training to get them up to the level of care and standard necessary to provide the services for these patients. And clearly the rate right now just in no way supports our ability to do that. And that's why in my testimony, I think you see some subsidization going on. Yeah, I am not by any way able to sustain and continue doing what we're doing in the rural areas. It's got to a point where it simply doesn't make sense. And we're a mission-driven organization, and we have been willing to subsidize those areas for a long time. We don't want to give up on those patients and those families, but it's reached a critical level. And so I'll end my testimony there and stand for questions about that.
For Sean. Senator Kirshen.
Thank you, Madam Chair. It's in a situation like in a rural area that understaffed, or what do you want to, if you put nurses in there or just one, is there any liability involved for negligence if you're not adequately staffed? How's that work?
That is a very interesting question. We always, as a medical provider, have medical liability. I mean, that's true for every medical provider of any profession. When obviously a significant portion of the cost to establish an agency and operate the service is to have adequate malpractice medical liability insurance in there. But when it comes specifically to your point of coverage, that has been a very delicate and heated issue that has certainly motivated providers, including myself, to pursue an adequate reimbursement rate, because there have absolutely been lawsuits. There have been some in the state of Kansas. There have certainly been some in other states where, even though the program is set up and it's specifically, I believe, stated this way, where, for a child to be able to discharge, there has to be a backup plan. There has to be family or there has to be a care network established to ensure that that child can get coverage for their needs if a nurse is not available for whatever reason. It could be, to your point, there was one nurse and that nurse now has COVID or has the flu or has something come up, and they can't come into the home. There has to be that backup plan. There has to be that backup care network and plan for that child. Even with that in place, we've experienced lawsuits, and the industry has experienced lawsuits from families that are claiming we had the responsibility to provide that service and we were unable to. So you're 100% correct. That is a huge concern with this.
Other questions for Sean? Senator Petty.
Thank you, Madam Chair. And Sean, thank you for being here. We've seen your testimony and heard from you before. I was looking at the information that you provided, and at this point in time, on the excuse me, on the Senate side, we've put in an increase up to $37 per hour. And I know in your testimony you mentioned with the reimbursement rate right now of 31 that means that you're only able to hire at $20 an hour. Is that correct?
As around a maximum rate of pay, correct? Because I think one of my testimonies, and I forget, Senator Petty, if you were on that testimony or not, but I actually provided a detailed breakdown of what percentage of the reimbursement is used for direct pay for the nurse, what's used for insurance, what's used for training, taxes, all that stuff. So there could be, some good clarity and understanding of what that pass through is. So, but if you apply the ratio roughly of that number to what the rate increase would be, you could see that we could get to a much higher base rate of pay for RNs and LPNs up into the mid-20s, up and even closer to 30 or $30+ an hour to pay the nurse versus what we're able to pay now, which is 20 or below.
Sean, you said that was in that previous testimony we had, you said it's in that?
You know, it was in one of the ones that I did it was either late 2019 or early 2020. I have to go
okay.
back and find which one that was.
Okay, so it wasn't this year's when we had our subcommittee? Okay.
No, and I believe it was before the Bob Bethel committee.
All right, thank you. Senator Petty, go ahead. Did you?
That's fine. He answered my question. I appreciate it.
Any other questions? All right, thank you, Sean.
Thank you very much.
Next, we have Ann Martin, MSNRN, Director of Operations of Thrive.
Good afternoon. Can you hear me?
Yes.
Hello, Ann Martin with Thrive Skilled Pediatric Care. Just to follow up on my colleagues, Matt and Sean's plea, from a nursing point of view, it is a very difficult situation to be the only provider in a home. So when you're talking about bringing a new graduate into a home to provide skilled nursing care, they need to know that they have backup. And they need to know that their new license will be protected. And at this current rate of pay that we provide, it's just not sustainable. We're asking nurses to stay up all night, be present all day if parents can possibly work, and be the only provider of skilled care. So I won't belabor the point. It would be wonderful to be able to pay our nurses more to help them pay off their education, their student loans. So thank you for allowing us to have this time and give our testimony, and our kids and families greatly appreciate it as well. Thank you.
And what is Thrive SPC? I don't know what the SPC means. And then also, what areas do you serve in Kansas?
The SPC is Skilled Pediatric Care. We provide care in Wichita, Salina, and Independence currently. Independence, as Sean mentioned, a little bit more rural, very hard to find nurses to serve that population. With regard to authorized hours, we staff those cases at about, say 50 to 60% of their authorized hours, their Medicaid authorized hours. And Wichita has a little bit better staffing percentage in the high 60s, low 70s, and Salina as well. But Independence really struggles to find qualified nurses who want to provide care at home.
Thank you. Any questions for Ann? All right. Is there anyone else that is on WebEx that wanted to speak today on this topic? All right. Is there anyone that already spoke? Back to Sarah and Amy, did you have any other comments or anything that may have come up during this discussion?
None for me, Madam Chair. I think I would agree with pretty much everything the other conferees have said.
And
Go ahead.
I did just have one question. I guess that maybe goes to Matt. You had, in the earlier testimony, you had mentioned about, well, Sarah had mentioned about the difficulty of being able to match the ability of having a nurse in the home and saying that reduces hospital days. And then you or Amy both said that that you see it as being possible to provide that information. So do you see that being, do you see that being something that your agency would be doing, or it's going to fall on the state to be doing?
I think it can be done either way. As the state does it, it's more universal data. as if we had providers do it, it would be fractured amongst the provider network. We do have testimony from Addie Bagley, who's a neonatal nurse practitioner, who did testify about the extreme amount of delayed discharges. So where we see a lot of the savings is when a child is ready to come home, or someone who's going to receive private duty nursing is ready to come home. Many times they don't come home at that time because the network is not able to set up services when they are ready to come home. What we think is that this rate increase would allow us to follow the needs of the patient, would allow when that patient is ready to come home to have the transition from hospital to home be seamless and set up due to the medical needs of the patient, not due to the ability to provide from the provider network.
I had looked briefly over Abby's testimony. Would it be accurate to say that like a child that's in the condition that she's referring to here, I mean, where you really need a specialized nurse, she also mentions about LPNs not having that training. So, I mean, even with a salary increase, I'm gonna make this assumption that in some cases, that's still, you're not going to be able to get that specialized person. Are you saying that with a salary increase, you're more likely to be able to get that specialized person that would be needed in these high needs cases?
Yeah, significantly higher success rate. Us being able to compete for the nursing staff to be able to provide it is absolutely necessary. So, you're not going to hear any provider guarantee services, as Sean talked about. You know, someone gets COVID, there's a void. You try to set up the backups as much as you can, but there wouldn't be a way to say absolutely there's a guarantee that 100% of services would be provided. But what the rate increase would give us an opportunity to do is compete with medical settings, compete for those nurses who work in those areas to be able to work within the home. And so our likelihood of finding and creating that universal staff to be able to transition from hospital to home is hugely increased with us being able to compete from a financial level at the same playing field as other healthcare settings.
Could I make a comment? The thing that was really overwhelming to me when I started helping Mary Ellen Conley work with this client was that their calculations show that they can offset this cost by reducing hospitalization days by 1.08%. They are not predicting to take care of all of the issues or that there won't ever be waiting. And so I think that's one of the most impressive parts of these calculations and the data that's in front of you. Thank you, Mr. Chairman.
What we'll do is we can either make a recommendation, add omnibus, or provide a report back, whole body prior to, I think with time running out, I'll talk to Senator Billinger, but I'd like for us to be able to, when we do omnibus, because we're going to come back that day, at some point in time, beforehand, and maybe we can provide some kind of at least report or recommendation. So I was going to ask Matthew, but if you guys already know, what did the House add?
Yes, the House came out of subcommittee at 47.
So
it's subcommittee, but it hasn't been approved. Has it been?
yeah, they haven't. I think they're doing.
I don't believe it's been.
They have had the discussion in committee now, but of course they'll go back and do that again now that you've done your work before they pass out their budget bill. Now, the chairman did tell me that this year they intend to have a budget bill, so that's a good sign. And we have been meeting with committee members and we have pretty good support. So we feel really good about it. Thank you.
So if the House does pass it, then that'll be a position in conference, and so we'll just monitor that, and if not, maybe we'll bring it up at omnibus if we need to. Is that? I don't see any further action that we need to do. Yeah. Okay, the only final question I have is, Amy, I don't know which country's annual celebration you were representing today. I'm just curious.
I know I failed today on the color dressing.
I could walk around, it could be Christmas. Okay.
Except I have to tell you that one of my colleagues, another senator, implied that this was not green, so.
Looks like green today. And thank you so much for spending the time for this deep dive. I know how hard it is to suss out the details of this issue in a hearing where you're hearing the entire agency. So thank you for doing this.
We appreciate the information. Anyone on WebEx has any final comments? Seeing none, we are adjourned.